So, Assalamu alaikum, Dr. Maryam again. And thank you so much for joining us today for this important talk. Dear colleagues, many of us already know Dr. Maryam, but let me introduce, my pleasure to introduce her formally. And Dr. Maryam Naim is Associate Chief of Research in the Division of Cardiac Critical Care Medicine at the Children's Hospital of Philadelphia and Associate Professor of Anesthesiology, Critical Care and Pediatrics at the School of Medicine, University of Pennsylvania. Dr. Naim is board certified in both pediatrics and pediatric critical care. Her clinical and research work focuses on cardiac critical care resuscitation, brain injury, and extra awards for her research and has contributed to over 100 peer-reviewed publications in leading scientific journals. Beyond her academic and clinical achievements, Dr. Naim serves on several editorial boards, national task forces, and diversity and well-being committees, demonstrating her commitment not only to scientific advancement, but also to improving system of care and inclusiveness in medicine. Please join me in welcoming Dr. Maryam. Thank you, Dr. Maryam, and floor is yours.
Thank you so much, Doctor. That was such a nice introduction. And Assalamu alaikum. It's so nice to see everyone in Karachi, and I wish I was there. I know it's nice and warm over there. यहाँ पर भी काफ़ी गर्मी है. मैंने कराची में 5 साल गुजारे थे, and there during medical school, and I have to say they were probably amongst the best years of my life. So I miss Pakistan, and I especially miss Karachi, and I hope I can meet you all in person one day. So I was asked to speak about postoperative inotropes and management with emphasis on patients with tetralogy of Fallot. And so the objectives of today's talk are to talk about postoperative physiologic considerations in patients with tetralogy of Fallot, to review the use of inotropes in the early postoperative period following congenital heart surgery, and they're going to be case presentations with problem solving. This being said, the spectrum of disease that we see in the United States is a little bit different from Pakistan. I've worked in Pakistan as well as in the US, and especially in patients with tetralogy of Fallot, the patients we see in the US are typically much younger patients. Many of them are young infants between 3 to 5 months of age, as well as neonates. And in Pakistan, my experience has been in taking care of much older children, and even some teenagers. So I know the presentation is different, but I think that the principles of perioperative care is probably similar. But again, I would say that my recommendations come with a grain of salt in that sense. So I'm going to present a typical case that we would have with tetralogy of Fallot, and this is a case of a 5-month-old who had a tetralogy of Fallot repair with Dacron patch VSD closure, RV muscle bundle excision, transannular patch, who had a tiny PFO that was left open. The bypass time was 200 minutes. Cross clamp time was 120 minutes. Chest was closed at the end of the case. Sinus rhythm, no bleeding. The echocardiogram shows no residual VSD. No right ventricular outflow tract obstruction. There's free pulmonary insufficiency. There's mild to moderate tricuspid regurgitation with good RV and LV function. The majority of these patients in our center are extubated after surgery. However, this patient was brought back to the ICU intubated as the surgeon and the OR team had another case that they had to do. So this patient comes back to the ICU intubated on dexmedetomidine, fentanyl, milrinone, and epinephrine. And you are called to the bedside because the patient is hypotensive, has a temperature of 39, and this is, a couple of hours after surgery. Blood pressure is low at 50/30. The heart rate is high. at 180 beats per minute. The RA pressure is 15, the saturation is 75. And you get a quick bedside echocardiogram that shows moderate RV systolic dysfunction, low normal systolic function of the LV, a possible intramural VSD that wasn't visualized in the OR with left to right shunting, and then there's right to left shunting across the PFO. So in terms of thinking about this patient and the kind of questions we ask ourselves, why is this patient hypotensive? So does this patient have RV systolic dysfunction? The echocardiogram is showing us that they do. Does this patient have RV diastolic dysfunction? We know patients with tetralogy of Fallot have RV diastolic dysfunction. Is this patient having what we call low cardiac output syndrome, which we see in children following cardiopulmonary bypass? We don't know that. We don't know what the mixed venous saturation is, and that's usually one of the things that we use to diagnose low cardiac output syndrome. Or does this patient have LV systolic? So hopefully by the end of this talk, I'll show you that these patients can be sick because of all of the above factors. So effective interventions to improve this patient's blood pressure include decreasing oxygen consumption with sedation, neuromuscular blockade, and trying to make them normothermic, optimizing preload with a fluid bolus, augmenting contractility by increasing epinephrine, adding vasopressin, and discontinuing milrinone. And again, hopefully by the end of this talk, you'll be able to understand that the interventions that we use to make these patients better often include all of these interventions. And then lastly, despite all these interventions, the patient continues to be tachycardic and hyperthermic and hypotensive and desaturated with saturations in the low 70s. Laboratory investigations show a very high lactate of 15, a base deficit of -10, and then effective interventions to include should include a milrinone infusion. I wouldn't start a milrinone infusion, and again, I'll show you why and what data supports probably not starting milrinone in this patient, a cardiac catheterization with intervention to the PFO, discussion with the surgeon about opening the chest, discussion with the surgeon about placing on ECMO. So some of these things are interventions that we may do for this patient. So again, the presentation and the interventions for tetralogy of Fallot in the United States are different from in Pakistan, where in the United States, especially at our center, in the northeast of the United States, the majority, or I would say all of tetralogy of Fallot cases are diagnosed prenatally. And so many of these babies are actually born at our center and undergo an elective repair between 3 to 6 months of age, which consists of the transannular repair, which is demonstrated over here, but very often they end up doing a transannular patch repair. And then if there is an anomalous or if the coronary artery is crossing across the right ventricular outflow tract, then in that case, an RV to PA conduit may be used. And then typically there's also RV muscle bundle resection with a VSD closure. So these patients have issues with right ventricular compliance. It is decreased after surgical repair for many reasons, but the first is really that these patients have very hypertrophied ventricles, especially when they have what we call blue tetralogy of Fallot or cyanotic patients. These patients present in two different subtypes. One of the patients who have a lot of pulmonary stenosis, the so-called blue TETs. We also have many patients that are, especially with this prenatal diagnosis and early surgical repair between 3 to 6 months of age, who are what we call pink TETs. And these are patients who basically have VSD physiology. So they behave sometimes quite differently from blue TETs. In blue TETs, we have these patients have a lot of RV hypertrophy from the pressure-loaded ventricle. And then after surgery, they have a pressure-unloaded ventricle, so that makes their hypertrophy even worse. The RV can also be sick secondary to undergoing a ventriculotomy. If related to the transannular patch, the surgeon had to extend the ventriculotomy to close the VSD. They can have a lot of pulmonary regurgitation, which also makes which volume loads the RV, makes the RV more sick. And in these cases, the RV compliance can lead to restrictive RV physiology or diastolic RV dysfunction. Now, we talk a lot about restrictive RV physiology and RV diastolic dysfunction, but really what is truly, how do we diagnose restrictive RV physiology? And this is really not only a clinical diagnosis, but on echocardiography. This was described by Dr. Cullen in Circulation many years ago. And it is really the occurrence of, and what you can see over here on this echocardiogram, over here you see this is systole. And over here, what you're seeing is that there is antegrade pulmonary blood flow during diastole into the pulmonary artery. And so the definition of restrictive RV physiology is really that antegrade pulmonary blood flow during diastole that you see in patients. In terms of helping them, we're going to talk a little bit about inotropy in a little bit, but it is very important to remember just very basic things that we can do in the ICU or even postoperatively in the OR to support them. And knowing that the patient, this right ventricle is preload dependent. And actually very afterload sensitive as well. So very often these patients require high filling pressures, and changes in venous return may affect pulmonary blood flow, and then increased RV afterload is poorly tolerated. So just speaking a little bit about venous return, the majority of total blood volume, and this is really going back to our physiology lessons from medical school. The majority of our systemic venous return is actually the majority of blood volume is actually within the systemic venous system. And that's 60% of the systemic volume is within the venous system. And then what you have over here is that you see that there's this I'm not sure who's got the pointer on here, but anyway, thank you for pointing that out. But what you see over here is that there's this venous reservoir over here, and within the venous reservoir, what you can see is that the VS that I'm pointing out over here is what's called stressed volume, and the stressed volume is actually what leads creates a pressure to drive venous return back to the atrium, which is the mean systemic venous pressure. And so what happens is that in situations where you have changes in right atrial pressure, which you see with diastolic dysfunction of the RV, there's decreased venous return back to the heart because there's changes to this mean systemic pressure. So either increased intrathoracic pressure, which you see with invasive ventilation, or a decrease in RV compliance, with an increase in RV and diastolic pressure will lead to decreased venous return. In terms of RV, so these patients very often, just to go back to this, very often need volume just to augment systemic venous return and to help them when they're hypotensive or have low cardiac output. In terms of RV afterload, this RV which has severe diastolic dysfunction or restrictive RV physiology is very sensitive to RV afterload. And as we know, the RV afterload is really created by the pulmonary vascular resistance, and situations where the pulmonary vascular resistance increases the afterload on the right ventricle, which includes acidosis, high partial pressure of oxygen, hypoxemia, and then lung volumes that are too high or too low that can increase vascular resistance in the pulmonary vascular bed. So again, and this is just going back to physiology from when we were in medical school. PVR is lowest when the lung volume equals the functional residual capacity. And then when you have a patient who has very high lung volumes, that will lead to an increase in PVR secondary to compression of alveolar vessels. And then when they're low lung volumes, this will lead to collapse of the extra alveolar vessels, which also increases the pulmonary vascular resistance. So how do we ventilate these patients? In general, we try to ventilate them with the lowest mean airway pressure possible. And what you're trying to achieve is ventilation that's close to FRC. So typically we will use a very low PEEP strategy, which is very different from what we use in the pediatric intensive care unit. So a PEEP between 3 to 5. And I know that 3 sounds very, very low, and it seems like it's subphysiologic, but that's what we use in these patients. And then we try to minimize their rate and really use a low I/E ratio. And in general, I would say that probably 90% of our patients are extubated in the OR, or if they're bleeding, they're extubated as soon as they achieve hemostasis in the ICU. So within the first 4 to 6 hours after returning to the ICU. However, the neonatal TETs, the patients who have a neonatal repair within the first month of life, typically these patients are very, very sick and they do remain intubated following their tetralogy of Fallot repair. A little bit about the LV, which I feel that we don't talk about a lot when it comes to tetralogy of Fallot. जब हम अपने students को भी सिखाते हैं, we always talk about the RV, RV, RV. And then I think that what's very often forgotten and what sometimes makes these patients very, very unwell is the LV in these patients. And so in patients who have this restrictive RV physiology, or patients who have very, very high right ventricular pressures, what happens is that the RV pressure is higher, and as a result, what you can see in this case, because of the higher RV pressures, the septum is moved over, and so you see a reduction in the LV and diastolic volume. There's also reduced contraction of the LV as well, just going by the LV Frank-Starling mechanism. And what data are they to support this? So again, this is an older study from circulation, where by echocardiography, the ejection fraction in postoperative tetralogy of Fallot patients was measured. And what you can see on the x-axis here is the end diastolic area change. And then on the y-axis, you have the ejection fraction change. And this is compared to their preoperative end diastolic areas and preoperative ejection fractions. And then they classify these 2 groups of patients differently. So the patients who shunt predominantly right to left, the so-called blue tetralogy of Fallot patients, versus the patients who shunt predominantly left to right. And this is across the VSD. Those are the pink tetralogy of Fallot patients. You can see, and what I want to emphasize over here is that in all patients with tetralogy of Fallot, the LV, and this is specifically looking at the left ventricular ejection fraction, the LV ejection fraction goes down in all of these patients compared to their preoperative baseline in both the pink TETs and the blue TETs. But what you can see that also changes is also their end diastolic area change. So now what happens is that the pink TETs have VSD physiology. So their LV is volume loaded preoperatively, and just like a patient who has a VSD closure with volume unloading, that ventricle, their end diastolic area goes down. Whereas with the pink TETs, they haven't been exposed to that high volume like the blue TETs have. And so you can see that there very often there can be a change in their end diastolic area, which actually goes up after surgery. I don't think that that's as important as just recognizing how their ejection fraction goes down. And again, very often we say, oh, we're not worried about the LV after surgery. We actually are very worried about it because this is why patients don't tolerate a residual VSD very well, because especially the patients with blue tetralogy of Fallot, they have not had a volume loaded ventricle. So now all of a sudden what you're doing is that you're giving this previously this ventricle that hasn't done very much a new volume load, and this can make these patients very, very unwell. So what are some other causes of complicated postoperative course in these patients? Patients with severe TR don't do very well because they have decreased RV compliance, especially in younger infants. There can be reperfusion injury after tetralogy of Fallot and pulmonary atresia repairs. And again, this is just because there was decreased pulmonary blood flow, and all of a sudden there's increased pulmonary blood flow in certain segments of the lungs. And so this can cause reperfusion injury. Aortic pulmonary collaterals, just like a residual VSD, have a residual right to left shunt, and this can make these patients very, very, very sick in the early postoperative phase. And one of the suggestions, if you echo these patients and they have left to right shunting across the PFO, usually patients with tetralogy of Fallot have right to left shunting. If you echo them and the shunting is left to right, this is a hint that they have a residual left to right shunt somewhere, or their LV and diastolic pressure is high. So switching to what we, or what I've been asked to talk about, which is what are the inotropes and vasopressors that we use in our patients early after cardiac surgery. And what I would say is that our practice, at least at the Children's Hospital, is probably very similar to the medications that you use in Pakistan, or at least that I've seen used in Pakistan, where very commonly, the medications we use to prevent low cardiac output syndrome, and so this is prevent and not treat, include milrinone, epinephrine, and dopamine. And even though I would say that our practice is moving away from using dopamine, we're using more epinephrine in the current era. We still use dopamine in some patients, and I'll go over the doses later. In terms of monitoring for the development of low cardiac output syndrome, we use arterial blood gas analysis and monitor the lactates in our patients. We don't use physical examination that much, or at least not as much as we should be using. But very often the nurses will tell us that this patient feels very cool. The urine output isn't good, they're mottled, and those are sometimes indications of low cardiac output syndrome. Then in terms of venous saturations, we do sometimes use venous saturations for diagnosis of low cardiac output syndrome. But again, if we're using the venous saturation, we have to make sure that we're drawing it from a reliable source. Sometimes we use intracardiac right atrial catheters that may not give us the best sample. Sometimes they can be measuring coronary sinus flow. Very often, venous saturation from a IJ line is more accurate, especially in the ICU. So this was a international survey that was carried out through the Pediatric Cardiac Intensive Care Society. This included, I think it was about 90 centers, which is what we have over here. And there were 4 centers from Asia in this. So, really representative of an internet and European centers as well as US centers. So representative of an international population. And this was published in 2018. And I would say that nothing has really changed from 2018 to now dramatically to in our practice of taking care of our patients. In terms of drugs that are used once low cardiac output syndrome is diagnosed, the most common first-line agent in this survey was milrinone. And then the most common, the second most common was epinephrine, and then this most common second choice drug was epinephrine as well. So epinephrine is very commonly used either as a first choice or a second choice drug, and then milrinone is the most commonly used as a first. And again, this is in just all patients, not necessarily just in tetralogy of Fallot. So just quickly, dopamine and the mechanism of action. So when we use dopamine, we typically use it at the dose of 2 to 5 micrograms per kilo per minute. And I apologize for the typo over here. So this should be mcg. And the major effects in this are renal vasodilation and maybe some increase in cardiac output. And so we usually maximize our dose at 5 mics per kilo per minute, because beyond that, very often what you see is that the patients become very tachycardic, and then they can develop arrhythmias. In the NICU population, the neonatal intensive care unit, you'll very often see patients on very high doses of dopamine, up to 20 mics per kilo per minute. But this is really not a practice that we do in the cardiovascular intensive care unit, especially since at those higher doses greater than 10, we also see increase in systemic vascular resistance that we don't want in our patients. So really, we want to see primarily the beta effect, beta 1 effect, which is increased inotropy. And again, at a dose greater than 10, we're going to see more arrhythmias, as well as the peripheral alpha 1 effects of really increased SVR. In terms of which patients we use it on, patients with circulatory failure. And the reason why I put dopamine here first is that I think that it's the drug that we're most familiar with, or many of us use it quite a lot. But again, as I said, that it's really something that we are moving away from, because we just feel that epinephrine, especially in the PICU literature, there's data that epinephrine is more effective than dopamine, and at least in the sepsis population. So just extrapolating that data to our patients following cardiac surgery, we've increasingly moving away from dopamine as an inotrope. Epinephrine, we typically use up to a dose of 0.05 mics per kilo per minute. So we try to avoid using higher doses in the cardiac intensive care unit. At this dose, up to 0.05 mics per kilo per minute, there's primarily just the beta 1 and beta 2 effects. So the beta 1 effect is inotropy, and a beta 2 effects of peripheral vasodilation. With the beta 1 effect, we also see chronotropy as well. And so it's a very, very, very nice medication. And if you've ever started under echo guidance, you can see that at that dose of 0.05, sometimes, especially if a child has diminished ventricular function, the heart really seems to wake up with epinephrine. We try to avoid using it at higher doses. So at doses greater than 0.1, you start to see some of the alpha effects with peripheral vasoconstriction, and we want to avoid peripheral vasoconstriction because we want to avoid increasing the afterload on the heart, as well as some of the other untoward effects that peripheral vasoconstriction can cause, like ischemia to other organs. So we will max out our epinephrine at 0.1 mics per kilo per minute, and usually use it at a dose of 0.05. So what does epinephrine do? It increases blood pressure, it increases inotropy, it increases chronotropy, it increases vasoconstriction, especially at those higher doses of 0.1 mics per kilo per minute. So again, in the PICU population, higher doses of epinephrine are used all the time, but in the cardiac intensive care unit, especially in patients following cardiac surgery, we avoid these higher doses because of the risk of ischemia and increased LV afterload. And then we use it again in patients with circulatory failure, and it's our primary drug in resuscitation. Norepinephrine is not a medication that we use very often and I'm just gonna be very honest. I don't think I've used norepinephrine in a very long time. It's a potent alpha-1 and a beta-1 agonist. The dose is listed over here. It does have more of an alpha-1 effect, and it really increases SVR. It is also an inotrope, but the predominant effect is really increasing SVR, and it can be a very good drug in certain populations. So, for example, if a patient has very severe pulmonary hypertension and their RV is blown out and the septum is all the way in the LV, and you want to give a drug that's going to improve coronary blood very often in the cardiac intensive care unit routinely. And again, it's indicated for patients with shock with decreased SVR. So really those patients are very vasodilated in shock. In our practice, when we have post-op cardiac patients that are very vasodilated and in shock, our preference is to use vasopressin. Dobutamine is also a drug that is excellent, but we don't use very often because we use dopamine and epinephrine more. This is a racemic mixture of two isomers. It has beta and alpha properties, and depending on what dose you're using, it's primarily a beta-1 greater than a beta-2 agent. And it's a good medication again. I think that we don't use it very much, but people who use it like it quite a lot. Also, at higher doses, it can cause quite a lot of tachycardia, but it's a good inotrope, and it can also cause peripheral vasodilation. Vasopressin is a medication that I would say that we've been using more in the last couple of years, and it acts on blood vessels as well as on the kidneys. In very low concentrations, it can lead to free water retention. At higher concentrations, it leads to vasoconstriction. And then there's not a lot of data to support what we do, but there is quite a lot of data on the use of vasopressin actually in children following cardiac surgery. And there is a phenotype of children who have low levels of vasopressin following cardiac surgery. And those are the patients that really benefit from the use of vasopressin. In my practice and in our practice in general, at CHOP, if we have a patient in whom we are on 5 of dopamine and maybe 0.05 of epinephrine, and we're thinking of a third agent to use, then vasopressin is the third agent we use. And what it does is that even in very low doses, it increases the blood pressure, and especially in patients who are unresponsive to catecholamines, for example, epinephrine or norepinephrine. Phenylephrine is used in our patients with tetralogy of Fallot. Similar to norepinephrine, it's an alpha-1 agonist. It causes vasoconstriction. The dose is listed there. And, our use is primarily in patients with tetralogy of Fallot. When they're having hypercyanotic spells, we'll give them a bolus of phenylephrine, sometimes lower than even, I listed 10 mics per kilo here, but sometimes you can just start with a mic per kilo and titrate it up. Milrinone is the most commonly used agent following cardiac surgery for either the treatment or prevention of low cardiac output syndrome. The dose is listed over here. It's an inodilator, which causes not only improvement in ventricular function, but it also causes vasodilation. It decreases the SVR and the PVR, and so it has a lot of beneficial effects following cardiac surgery. There's data in animals that it's a lusitrope, helps in ventricular relaxation. There's no data in humans to support that, but there are animal data. The half-life, however, of milrinone compared to the other inotropes that we talked about is very long. And so if a patient, and it's 2.5 hours if a patient has normal renal function, and then, as you know, many of our patients following cardiac surgery have impaired renal function or acute kidney injury, and so the half-life is much longer in those patients. Who do we use it on? We use it in patients with heart failure, with low cardiac output syndrome. We use it with caution, but we use it on patients with pulmonary hypertension, and then we use it in patients with right heart failure after cardiac surgery. Now, even though milrinone is all of us, like especially those of us who work cardiac OR and the cardiac ICU, love milrinone. I'm going to present some data just to show that even though it's a good drug, I think we should use it with caution. And I question its use into patients with tetralogy of Fallot and also in patients following the Fontan operation. And I'll show you some of the data. So some of the data to support the use of milrinone came from this old study. There are not many studies in cardiac critical care where patients are randomized to different treatments, but this was the PrimaCorp study, which is a multi-center study in which patients with biventricular circulation, including patients with tetralogy of Fallot, were randomized to 3 different groups of no milrinone or placebo, low-dose milrinone, and high-dose milrinone. And the incidence of low cardiac output syndrome measured by mixed venous oxygen saturation was measured in these patients postoperatively. And high-dose milrinone, both high-dose and low-dose milrinone reduced the risk of low cardiac output syndrome following cardiac surgery. But it was the high-dose milrinone that really caused a significant effect in the reduction of the incidence of low cardiac output syndrome following cardiac surgery. So since the study, I would say that milrinone has really, it's really something that all of us use. In the past, I would tell our fellows that in the middle of the night when our patients were hypotensive and in shock, I would say continue the milrinone because it's the only medication that we know that works after cardiac surgery and preventing low cardiac output syndrome. But recently, I've started thinking differently about this because it is a vasodilator, and it not only vasodilates the arteries, but it's also a venous vasodilator. And so there's this very nice paper that came out recently from Boston Children's. It's in the last 2 years, where they looked at the effects of milrinone in patients with tetralogy of Fallot, and they compared 2 groups, a group that received milrinone compared to a group that did not receive milrinone. And then they compared their hemodynamic characteristics as well as the amount of volume these patients received. So what you can see over here is the heart rate in patients who receive milrinone compared to no milrinone. And what you can see is that the heart rate is much higher in patients who receive milrinone compared to those that don't. The systolic blood pressure is lower in patients that receive milrinone compared to no milrinone. The red is the milrinone. And then you can see the diastolic blood pressure is also lower in patients that receive milrinone compared to no milrinone. So you'll probably say that, why does it matter over here? When you look at the systolic blood pressure, the majority of these are infants between 3 to 5 months of age who had tetralogy of Fallot repair, and the lowest systolic blood pressure you're seeing even with milrinone is 80. So that doesn't sound too bad. The lowest diastolic blood pressure you have over here is 45. That doesn't sound too bad either. But when you look at the amount of volume that's administered to these patients, what you can see is that at every time point after surgery, the milrinone at almost every time point, especially in the immediate 24 hours after surgery, more milrinone was administered to patients. More volume was administered to patients who received milrinone compared to those who didn't receive milrinone. And the mechanism for this has been proposed to be going back to that same venous curve that we talked about at the beginning. So we talked about the stressed volume that is very important in creating that mean systemic pressure to drive venous return back to the heart. what happens with milrinone is that the patient becomes very venodilated. So what happens is that the stress volume really goes down in these patients. And so there's no driving pressure because the patient's venodilated, there's no driving pressure to drive blood flow from the periphery back to the heart. And that's why we end up doing a fluid resuscitation in these children. So milrinone may not be the most beneficial drug in patients with tetralogy of Fallot. And so recently, I myself have moved away from using milrinone, or at least stopping it early if the patient has a high volume requirement. It seems like it goes against everything I've been taught as a cardiac intensivist, but I have noted that both in patients with tetralogy of Fallot as well as our Fontan patients, we have to give them much less volume following surgery when we avoid milrinone. So again, it sounds quite bad that I'm not recommending this, but I would say that I would try using lower doses of milrinone, or even some of the patients that do very well after surgery, avoiding milrinone or stopping it early, and you'll see that you probably use less volume in those patients. So what are the other important considerations following tetralogy of Fallot repair?
Are you with us?
So we worry. Yeah, go ahead, Dr. Fatima. Were you saying something?
No. It was just a interruption, internet interruption.
Okay. So other postoperative considerations include I just want to make sure I do this right. Okay. Some other important postoperative considerations in patients with tetralogy of Fallot or any other surgery are bleeding and tamponade, arrhythmias. We talked about RV diastolic dysfunction, increased volume load. We talked about low cardiac syndrome and ventriculotomy, sometimes to close the VSD. And how do we manage low cardiac output syndrome in our center? So this really starts with anticipation. And I would say that the care of the patient really starts in the operating rooms by anticipation by our surgeons and our anesthesiology team on what these patients will require post-op. So if a patient has a long and very complicated surgery, they're brought back to the ICU, intubated, sedated, and paralyzed. And these, as I said, the neonatal tetralogy of Fallot patients for us are very unwell. And so when we do have to do this surgery, as in the patients, we decide to do a complete repair in the neonate, which is a select number of patients. We typically do BTT shunts in the neonate, but in those that we decide to do a complete repair, these patients can be quite sick initially, but overall do very well. Many of them come out on epinephrine and milrinone. And then we really try to minimize interventions that increase myocardial oxygen demand or increase systemic oxygen consumption in the first 24 hours. And then there are other reasons where the right heart may be sick after surgery. As we know, these patients have very hypertrophied ventricles. And so sometimes the cardioplegia may not get to the most distal part of the myocardium. The right heart coronary may also be more prone to embolization. And when the surgeon leaves an intentional right to left shunt in tetralogy of Fallot, it really allows the left heart to fill without the right heart having to eject all the systemic venous return, and really limits the elevations in central venous pressure. So even though these patients are desaturated, they have improved cardiac output. And so we really trade hypoxemia for improved cardiac output. So, we always have the saying, the blue is better than gray in our patients with tetralogy of Fallot. Again, the support begins in the operating room. For our neonatal and infant cases, as well as for all our cases less than 40 kilos, we use modified ultrafiltration in the OR. Delayed sternal closure is really used on a case-by-case basis. It's never routine. And then, as I said, we preserve right to left shunts in select cases. And then these are, I already told you, our typical drugs for infant and child repairs. We use low dose epi, low dose dopamine, typically low to moderate dose milrinone. And then when these patients come back to the ICU, we do continuous monitoring with hourly ABGs initially, with a lactate probably for about the first 3 to 4 hours after surgery, and then we space out their arterial blood gases. We get an EKG routinely, especially in cases of tetralogy of Fallot. We want to make sure that these patients are in sinus rhythm. If they're in junctional rhythm and they have this diastolic dysfunction, they really require atrial pacing to augment their cardiac output. The patient goes into junctional ectopic tachycardia. We use amiodarone to treat that, and then obviously use pace them if they have complete heart block. If a patient is hypotensive and has low RA pressure, we give them volume. If the RA pressure is high, in addition to the use of inotropes that we already talked about, if we're over epi of 0.05 and dopamine of 5, we start low dose vasopressin, and we almost always use stress dose hydrocortisone if we're having to escalate inotropic support. And the bolus dose I put over there, and then we continue that a stress dose hydrocortisone for at least the first 24 hours. We have a very low threshold to get an echocardiogram. And then our typical sedatives and analgesics are dexmedetomidine and Tylenol. If the patient's intubated, we give them fentanyl. If they're extubated, we give them morphine. And then in the tetralogy of Fallot population, we use ketorolac early to minimize opioid use. Some of the data to support steroids, the use of steroids, there's a lot of concern that people brought up in the past about using steroids, especially in the context of overall the risk of mortality after surgery and whether they may be associated with infection. This is a systemic review that was published by the Cochrane Library, and they found that there was no change to the risk of mortality. And then this wasn't just steroids in the ICU. This was also steroids in the OR, and there were really no significant adverse effects either. So there are, as I said, that this is our routine practice, and many others may not have this practice, but it does, especially when we're having to escalate inotropic support, it prevents us from using very high dose inotropes. As I said, that we try to avoid going above 0.05 of epi and 5 of dopamine in our patients. What about ECMO and mechanical circulatory support? If our patients are on the dose of inotropes that I mentioned and they have a rising lactate, despite that inotropic support, we've started steroids, we've started vasopressin, and they continue to be hypotensive, then we'll electively place them on ECMO, and then we'll perform early catheterization to assess for residual lesion. And then so we'll do an early catheterization to assess for a residual lesion. So in conclusion, patients with tetralogy of Fallot are well known to have RV diastolic dysfunction after cardiac surgery, and but usually LV ejection fraction is also reduced. Therefore, residual left to right shunts are not well tolerated. Postoperative care starts in the OR, and then we should have a low threshold to investigate if a patient has a residual lesion if they're not progressing. And that's it. I'll open it up to questions now.
Thank you so much, Dr. Maryam. It was amazing learning, you walk through from anatomy, physiology, pathology, and whatever we asked you. So can you share how you integrate neuro monitoring or lactate trends into your decision for accelerating or de-accelerating support? As you shown the paper that, first of all, like in the low cardiac output, usually the people follow the trend of lactate and then the physical exam. And in that list also the nurse was written. So do you
I think that so for example, if the lactate remains, very often the patient looks quite good, but the lactate may still be high. So you may not, that the way that we use that information is that you may not, so for example, the patient's still intubated, if the lactate's still high, even though everything else is good, blood pressure is good, saturations are good, and everything else is good, you may wait till the lactate normalizes before you extubate the patient. Or if the lactate is high and the patient's extubated but still on milrinone, you may wait till the lactate clears to stop the milrinone. So I do think that we do incorporate, even if the numbers look good, if that one number is high, I do think that we do rely quite a lot on it. That being said, that the lactate isn't always high because of low cardiac output, and it's important to know that you can have a type 2 lactic acidosis when a patient is hyperglycemic. And so very often the patients may have another cause for high lactate. Usually in the cardiac ICU, it's low cardiac output. But if you get a mixed venous saturation, and that's reassuring, and the NIRS is reassuring, we use NIRS as well. But the patient's hyperglycemic, then you can just ignore the lactate and move the child along. So I think that I think the more monitoring you have, the better it is. And then in terms of neuromonitoring, we use NIRS, we use cerebral and somatic NIRS, but I don't think that the cerebral NIRS is always normal. It's never abnormal. It's the somatic NIRS or the difference between the two that indicate low cardiac output syndrome. When the somatic NIRS is low, because usually babies and children will preserve blood flow to their brain, so the cerebral NIRS remains normal, but the somatic NIRS goes down. So the neuromonitoring that we use is just EEG in neonates, and we typically don't use that to, if the patient's obviously seizing, we're not going to extubate them. We won't extubate a neonate, but other than that, we don't necessarily use the neuromonitoring to guide our postoperative management necessarily.
In our population, a lot of patients undergo complex surgeries and the sometimes are really high. So the patients that I think have a mixture of complications. They come with low cardiac output, they've got vasofagia, a couple of patients have increased PVR. So how do you guide your inotropic and vasopressor support? Do you rely more on SCVO2 or mixture of SCVO2 and lactate clearance? We've also got etimetry and we use it very regularly. But what exactly is your practice in that way?
I think that, I would say that like the typical monitoring, like I told you, is like NIRS, arterial blood pressure, and then we don't use the non-invasive cardiac output measures. Like, do you have PICO or anything like that? We don't use that. They use it in adults, but we don't use that. The cardiac output monitor that's attached to the arterial line, we don't have that one. But in terms of like patients who have multiple complications, I would say that, the patient, for example, who has pulmonary hypertension and significant post-op residual disease, I think the principles are all the same, that like, you probably, especially in that first 24 hours after cardiac surgery, you really want to minimize their oxygen demand and, optimize oxygen delivery. And then especially if a kid has pulmonary hypertension, we use nitric oxide. In Pakistan, I've worked at Tahir Heart Institute, and over there we just start sildenafil in the OR, so we have a slightly different practice there. But I think that the things on the ventilator are all the same, where we don't allow the patients to get acidemic or acidemic or either or hypoxemic. So very often you just have to work with what you have, and I think that just having a good understanding. The most important thing is just to know what's going on, and to, even if you've been told that everything is fine, to just constantly just question whether everything's fine, because especially when you work in the ICU long enough, when things are fine and things aren't fine. And when things aren't fine, I think having a low threshold to do an echocardiogram to see what's going on or reassess what's going on is very, very important.
Very good.
I would like to ask about the choice of norepinephrine versus vasopressin. Is it just used in the case of vasodilation, or you just, as you mentioned, that if you have to escalate inotrope to use?
We don't use, हम बिल्कुल norepinephrine नहीं इस्तेमाल करते, zero. We never use it. We use vaso. I don't know if you guys have vasopressin. हम vasopressin इस्तेमाल करते हैं. तो same patient in whom you would use norepinephrine, maybe that patient who's vasodilated or vasoplegic, we use vasopressin. And with vasopressin, I think even with a lower dose, the nice thing is that you get the properties of vasoconstriction, and you don't see as much vasoconstriction of the blood vessels, but you don't see peripheral vasoconstriction. So our preference is to use vasopressin. We don't use norepinephrine at all.
And yes, it is available.
Sorry?
Again, I would like it's available. Vasopressin is available in Pakistan.
Oh, vasopressin is, yeah. Again, you know, when I trained over here, we very rarely use vasopressin because our previous era of surgeons at CHOP were very quick. And so because our cardiopulmonary bypass times were much shorter, till 2018, I would say that we rarely used anything. We just used dopamine and milrinone. And then we had a change in our surgeons, and since then we have definitely longer bypass times, which are very on par with bypass times in other centers. Since then, we've had to use more epinephrine, and we now use vasopressin as well in some patients. But I would say that very rarely in older patients, mainly in neonates.
Dr. Maryam, some of the patients were very, very blue, like patients coming up to us with saturations of 40s and 50s. Obviously have LV diastolic dysfunction. Now, post-operatively, they've got elevated CVP, and traditionally we've been taught that post-op give fluids, give a bit of basic, give fluids. But over here, we have kind of realized that patients who are very blue do not tolerate fluids well. So, would you prefer early use of inotropes in such patients rather than with giving fluids?
Yeah, I think that those are the patients, like especially if they're still intubated, those are the patients who don't always benefit from milrinone, and there's sometimes you make them even worse when you give them milrinone, क्योंकि उनका, जैसे मैंने बताया था, they become vasodilated, and so they need higher filling pressures for cardiac output. So I would say that in those patients, you should consider epinephrine for, to help with RV and LV systolic function. And then even something like vasopressin, which may cause vasoconstriction of the blood vessels on the venous side as well, and augment cardiac output that way as well. Because you want to increase venous return back to the heart as well. So you're thinking about that, because that's why we give fluids, right? Is to improve the venous return or improve cardiac output. But by adding something like vasopressin, that can be beneficial. Again, low dose, you don't have to use high dose. The paper that I mentioned, this one, definitely read it, because I think it's a really good paper, and it changed the way that I think of these patients, the TETs. The other thing, in a patient who's very, very blue after surgery for tetralogy of Fallot, the patient shouldn't be super blue, right? If the PFO is too big, they're going to be very, very blue. So it may be that the PFO is too big in that patient.
So, Maryam, thank you very much. This is Babar. Thank you very much for staying up late and giving this amazing talk. I think it really has improved our understanding in multiple ways. And I think khulasa jo hai wo yahi hai ki sit at the bedside, understand what your working diagnosis is, and then keep on questioning and keep on working on it. Dynamic ICU is all dynamic, and once you are on top of things, you will figure it out, and then more inotropes, and these are all art of medicine, and then you just kind of add that and get your patients through. So truly an amazing message that you have sent to all of us. Thank you very much.
Okay, I hope it was helpful. It's very hard for me to say कि ये करना चाहिए जब आपका environment बहुत different है from mine, but I would say that having worked in Pakistan, I know that the patients are different and they present differently. But the treatment strategies are all the same. You guys have all the same medications. So hopefully this is helpful, and hopefully I can come one day to Pakistan and get to see how you work at SIUT as well, and hope to lecture you in person one day, inshallah. Okay, thank you.